The benchmarking tool is a sheet for healthcare interview, which is open-ended. So the strengths which we found were availability of TPT regimens, screening and diagnostic services were available. Active implementation of shorter TPT regimens, 3HR and 3HP. We found also there is a structured data recording and use, and novel tools have been introduced, the diagnostic and screening. For example, CAD technology is within 31 facilities and 5 mobile vans in our country. The facilities have been introduced with treatment diagnostic algorithms. Are also using tool for diagnosis of TB for under 5, and we use LF-LAM. We've just introduced this year for PHIV with advanced HIV disease. We also found that there is a national monitoring of pediatric specific indicators, which were divided, segregated by different age categories, 0 to 5, 5 to 9, and up to 19. There is also a robust DOT system and a weight-based dosing. And the challenges which we found were low or improper household contact screening, and we developed the action points to engage into a follow-up of household and closer contact investigations, to invite all children and assess TB, in assessment for TB. There is also a turnover or retirement of qualified provider who have trained and have good knowledge. Therefore, our plan is to have a good succession plan to train the newly assigned DOT. And if there is no funds, we've conducted the on-job training, mentorship, and e-learning trainings. Also, there was inadequate knowledge of pediatric diagnosis, low community engagement. Currently, there is a fund is freeze from USG, so this has affected us, and the community health worker support is no more there almost in many parts. And also there is a lack of job waits for pediatric TB diagnosis and management. For example, there's no scorecard, TDA, and other tools. So we are planning to have an e-learning alternative in order to minimize the cost of capacity building. Use the clinical diagnosis, which affect pediatric notification. Currently, we are using the new treatment diagnostic algorithm, and we have established the new TB diagnostic algorithm, which emphasizes on the bacteriological confirmation. Therefore, we are planning to do the capacity building. Also, the finding on benchmarking and standards, which was done at the national level and then shared during the stakeholder workshop. As you can see, we have several areas, around 9 to 12 areas, and these were the findings. There was a political commitment, and the yellow ones are partially met indicators, as you can see. And then we highlighted the challenges and the agreed action plans. So we have several agreed action plans and challenges. For example, on political commitment, we agreed to finalize and disseminated updated national guidelines, revised tools, because the challenge was on the issue of guidelines and SOPs. Concerning technical working group challenge, we are planning to integrate the TWG, pediatric, TB, HIV, and all other TB TWGs as one technical working group due to fund scarcity resource. And also concerning guidelines and SOP, we are currently developing our new guideline for pediatric and adolescent TB. So the agreed action plan emphasizes on finalization and dissemination. And you can go through the rest. I will share the presentation. And concerning the stakeholder focus group discussion, it involved mainly the stakeholders who were in a stakeholder meeting were invited in another meeting, which was mainly for stakeholders focus group discussion to assess the benchmarking and planning tool relevance, utility, and adaptability. So the findings were that there was a comprehensive and alignment with TB cascade, in a sense that the BNP tool aligns very well with the whole TB cascade, and also it facilitates strategic planning and monitoring. And we are currently using the results of our findings to formulate our new national TB and leprosy strategic plan. We have also used in end-term review, which has just ended last month. So the results of benchmarking and planning tool were also used. We found that it also had a flexible adaptation across all thematic areas. And our recommendation is that benchmarking and planning tool would also be used in another TB interventions apart from pediatric and adolescent TB. As a BNP tool, it also promoted data-driven performance assessment, because at the BNP tool, there is a section for monitoring, and we collected different indicators, and they helped us in decision making. The areas for improvement in BNP tool, which were stressed by the participant of FGD, were the need for clear questions, description, and standardizations. Limited stakeholder participation. Most stakeholders should be included to participate in BNP tool. Complex section for subnational levels should be there. Also, gaps in data integration and scoring system, especially when we had a challenge with inconsistent partial met. The user of BNP tool have experienced the challenge, because when you score a response as partial met, the overall score turn into a not met, and this tries to undermine our efforts. So many people disagree with this scoring system. So I hope KNCV are going to improve it. And concerning the best practice which we trying to find during the assessment is that Tanzania has innovated a new approach in domestic financing mechanism, which is based on levy collection across multiple economic sectors and channels, as per National AIDS Act. And in response to our government has formulated another Finance Act of 2025 to ensure sustainable funding for HIV/AIDS services and universal health coverage. This innovation target to raise around $220 million from new domestic source annual. And in the next bullet, you can see the list of the domestic sources. From alcohol, we've introduced the HIV response levies on minerals, train ticket charges, airport service charges, gaming and betting taxes, motor vehicle, and import level. And I've provided the link where you can access in detail this best practice. And to conclude, we have just concluded that the BNP tool in our country has enhanced the the visibility and prioritization of TB, pediatric TB gaps, and it has also helped us during the end-term review and national strategic plan development. And therefore, we recommend the finalization of publication of the results and its disseminations. And also, we recommend BNP tools to be adopted in our country, and also BNP tool to be applied across all TB interventions. This is the end of my presentation, and I would like to thank you all. Back to you, Mr. Chairperson.
Thank you very much, Peter, for the detailed presentations and also sharing the experience of Tanzania working to generate more domestic funding for TB and HIV. So I think that, that's a good example to share with other countries, and where also we can find more ways of generating also funding, domestic funding. So we will continue with the next presentation from the Gambia. So I already presented the presenter from the beginning, Mohamed Lamin, who's working at the National Leprosy TB Control Program of the Gambia, so leading the MNE department and supporting the National TB National Leprosy TB program, so on MNE activities. So Mohamed will share the experience from the Gambia.
All right, thank you very much, Dr. Mbenga. If Peter, if you can please stop sharing. And I hope my screen is visible.
Yes.
Right. So thank you very much, Dr. Mbenga. I am Mohamed Lamin Dabo, and on behalf of the Gambia team, I would be presenting our experience on the self-assessment tool and the sharing of the best practices for improvements in TB service delivery for children and adolescents. And just to begin with some acknowledgements, we've had a good team that worked on this, and I'm doing the presentation on behalf of them from the KNCV end and from the Ministry of Health as well, and other stakeholders in the country. So the presentation would begin with some context on TB in the Gambia, with a focus on childhood TB, to how the assessment was done, and would present some of our key findings and what are our agreed priorities, the expected outputs, and some lessons we have learned from this assessment. So to begin with, usually people tend to confuse Gambia with Zambia. So just to be clear, we are a small West African nation surrounded on all three sides by Senegal, and on the other side, we have the Atlantic Ocean. And if you look at our map of the Gambia, the dots that we have represent all the dot sites that we have in the country. So fairly, we have a good distribution of dot sites across the country. Although our national strategies have a provision that we should have a dot site in every district, we have about three districts that are yet to have a dot center. And however, we are working towards that, but there is fairly a good distribution of dot sites across the country. So to go into the epidemiology of TB in the country, before I go into the assessment in detail, as a country, we've seen a consistent reduction in the incidence of TB from 5 years ago when we had about 158 to 2023 when we had about 142. And our new estimates are showing about 138 per 100,000 population. So there has been quite some improvements in the incidence of TB in the country. Moving to the estimates and how far we are doing with our estimates. There is an estimated 3,800 TB cases in 2024 in the Gambia. Prior to this, we have about 3,900 estimated in the last 4 years. And since after the COVID, we have seen a consistent increase in the number of TB cases that we are seeing as a country. And this has slightly reduced during the COVID and just after the COVID pandemic. Then as a country, we've been on the path to recovery from the COVID since then. And for childhood TB, our national strategy provided that 10% of TB cases are supposed to be childhood TB cases. And the gap in childhood TB is even more severe compared to when we put the entire population together, because only 5% of our notified cases have been seen. So that means only 50% of our target as a country has been achieved. So the other 50% are still part of the missing TB cases. And our notification as well, as I said, in the last 5 years, we've been dwindling between 5 to 7%. And in 2022, we got 7%. But since then, it's been 5% over the period. And in terms of male and female, we are seeing more girls having TB compared to boys in our setting. When you compare this to the general population, we are seeing that more men are having TB compared to women. So. And on tuberculosis preventive therapy as well, when we look at eligibility and enrollment for children 0 to 4 years, it's about 85%. And for older children, 5 to 14 years, is about 72%. And a similar trend also is seen in the completion. We look at the 2023 cohort, about 83% to 7 compared to 72% for older children. So mainly we are using the three months regimen of weekly isoniazid plus rifampicin as a regimen currently. And in terms of our treatment success for DSTB, we've achieved about 95% for the 2023 cohort of child TB cases. And as a country, we've not had a single case of drug-resistant TB in children for the last decade. So moving to the assessment and what we did, I will begin with the objectives of the assessment. Our objective was to evaluate how far we are aligned with the global recommendations on management of TB in children and adolescents, and also try to see how well our screening is integrated into our existing health system using the KNCV benchmark and planning tool. So the approach, similar to what other countries have presented, we use the tool to do a DEX review of the policies, the guidelines, and the program data that is available, wherein we looked at indicators that cut across the cascade of care, from screening down to end of care for TB, including tuberculosis preventive therapy for contacts. So we had some key informant interviews as well with our stakeholders, including staff from the NLTP, to see how well does this tool, can this tool be utilized. And we've had experience using similar tools. However, the difference that we saw with the new tool is the fact that it doesn't mask the problem of children and adolescents, unlike the tools that we were using earlier, which tries to put everything into one basket. And when we do that, the problem that is specific to children and adolescents is sort of masked. But with this, we're able to bring out that component of this vulnerable population. We did a facility assessment in public and private facilities, and we made it such that we have one facility that is public from the urban area, one that is public from the rural area, and we did one for private facility. to see whether we'll be able to pick up some differences. We also did a stakeholder mapping, and where 18 organizations were brought together that are involved in the care of children, and findings from the data, findings from the health facility assessment were presented, and based on that, we were able to identify some roadmaps that we can follow to be able to be aligned with best practices. So this is just the list of all the stakeholders that were identified and were part of this workshop. And this includes those from the National Assembly, from research institutions, and disease programs within the Ministry of Health. So basically, we draw from institutions that are involved in nutritional services, child health and reproductive health services, immunization services, laboratory services, essential medicines, that's our national pharmaceutical services, and disease surveillance and capacity building and research as well. Just so we have a mix and be able to also target universities that are doing teaching and learning so that some of these things are captured. Service trainings. So our self-assessment, I will present it in terms of strengths and weaknesses that we have seen based on the tool. First, with the strengths, we have a national guidance that exists on how TB should be managed for children and adolescents. And there is evidence of political commitment from our National Assembly and executive as well. And the national policies ensure that all pediatric care providers involved in the care of children and adolescents, care for TB as well in children. And our national strategy includes preventive treatment for all eligible children and adolescents. And investigation of child and adolescent contacts of people with infectious TB is also part of our national strategy. However, when it comes to the weaknesses, we have seen that although the strategy exists, however, some components of the strategy are not implemented in totality. An example is the 4-month SOTA regimen for children with non-severe TB, although our guideline provided for how this should be done because of capacity issues and availability of equipment and materials probably required are not available to be able to do this. We've also seen through the stakeholder workshop that we had a weak integration of our services from immunization services, nutrition programs. All of these tend to not be integrated to ensure that care that is needed for a child is holistic and provided for every service that is required. Our national guideline is updated in line with the WHO recommendations. However, we were not able to have this available to facilities in hard copies. Currently, is available in soft copies, which is another weakness that we have seen. Our data disaggregation system as well do not adequately capture TB among adolescents. I think this has been one of the gaps that we have identified and are working towards fixing it with the use of an electronic database surveillance system, which is already been ongoing in some facilities and hopefully to be rolled out across the country. For coordination as well, we have a committee that is responsible for TB and HIV. However, no specific committee for children and adolescent TB care. And what tends to happen is, although child and adolescent TB is discussed in these meetings, but because of the sheer nature of how the meetings are organized for, say, TB and HIV, their problems tend to be sort of diluted into other issues, especially when HIV discussions around HIV would come up. So our facility assessment also looked at various domains, and again, we will try to present this in terms of strengths and weaknesses, beginning with the TB screening. All facilities conduct symptom-based screening and the use of chest X-ray. However, the weakness is that this is not systematically done for all our clients that have TB-related symptoms. And we're working towards how do we ensure that systematically every client that has a TB-related symptom is captured at an early stage and put on treatment. Moving to TB prevention, when we look at the public facilities, they're providing these services in total. However, the private clinic that we visited, just like many other private facilities, are not providing these services, and usually would, through a linkage to other facilities, these services would be provided. But it's a gap because along the way you tend to lose some patients as you keep referring from one facility to another. In terms of diagnostics, our public facilities again have on-site gene experts. But the private facilities, again, only one private facility has a gene expert in the country. And this tends to delay diagnosis because they rely heavily on the sample referral network for sample transport and feedback, which takes time. So for TB treatment regimens, the public facilities are providing the standard DSTB regimens, the 2 months of HRZT and the 4 months of HR. And the DRTB, we have quite a number of options, including the shorter regimens of BPAL and the BPAL-M. But for our private facility, again, just like most private clinics, does not offer DRTB management in general. In terms of guidelines and job aids, we have guidelines that are prepared, but they are available only in soft copies. And the childhood TB guidelines need to be available to facilities in copies that they can reference in hard copies. In terms of staffing and training, in-service training was limited across. The public facility at least have, in their pediatric units that we have done the assessment, at least 2 trained staff. However, in the private clinic, only 1 trained staff had undergone in-service training for TB. And based on all of this, when we put all of this together at the stakeholder workshop, we were able to come up with priority areas and some technical assistance needs. And the first one is to scale up the TPT and the Form 1 regimen. And the TPT currently is not scaled up to all adolescents. We're giving up to children up to 5 years. And we need to have this scale up. And the Form 1 treatment regimen for non-severe DSTB, again, also, we need a roadmap on how we go about this and an implementation plan on how to have this up and running. The second priority area was to update our TB guidelines and integrate into the IMNCI protocol. And the current guideline is updated. However, one key component which was missing was the management of DRTB contacts. We want to have this component integrated and have this in the IMNCI protocol, because the IMNCI unit tends to train a lot of staff. And when it is in their protocol, the pool of people that would be trained on TB would increase. The third is to integrate TB screening into our routine nutrition adolescent health clinics. And our need is to develop a roadmap and also to support the implementation to integrate TB screening into nutritional and maternal and child health units. And for some of these discussions have started on how we go about it. For instance, we are looking into having a dialogue with the nutrition program to see how this can be done. And KNCV equally is putting in some support to see this too. The fourth priority was to print and disseminate job aids and training tools. As I said earlier, the tools are developed, but they are not printed and distributed to the facilities. Again, we have seen a difference in terms of how the private facilities operate compared to the public facilities. We want to see how do we develop a strategy that is going to support the rollout of the public-private mix or partnership strategy, such that private facilities are able to provide an equally quality care that is needed for TB patients instead of a referral to other facilities. We're looking into point-of-care diagnostics as well. And we are seeing how do we support the procurement of point-of-care tools, including portable X-rays for use in community and congregate settings as well. Because we've seen delays in TB diagnosis, and to address that, the care has to start from the community. And the 7th point looks at how do we coordinate TB care. And we are looking into how do we have a child and adolescent TB technical working group so that their issues are discussed and independent of other issues like general TB patients or HIV, TB and HIV patients. And lastly, we are looking into community TB care to ensure that care is available to people at their communities. So we're looking into developing a community TB strategy and to support the implementation of this strategy in our communities. So if we're able to put all of this together, it is expected that we will have an improvement in our prevention, detection, and management of TB in children, and would reduce the delays that patients face to access care and also mortality related to TB. We would also be able to integrate certain services, thereby strengthening the primary healthcare structures that we have in the country. And through this, we can ensure sustainability through multi-sectorial coordination and country involvement and ownership. And this has also supported informed strategic direction, and it's a direct contributor to our national strategic plan for TB. Some of the lessons that we have learned, and the tool has helped the program to be able to identify actionable gaps when it comes to childhood and adolescent TB, and we're able to identify some of the strengths and the gap. And the stakeholder engagement has also helped translate findings to meaningful and actionable country priorities, where all the stakeholders sit together and brought out what needs to be done next. And this, we hope, sharing of this can help our peers and in other countries, and equally, just like we have learned from countries that have done this, Ethiopia, Tanzania. And lastly, we did a focus group discussion. I had mentioned this in the methodology, which is looking at the feasibility and the utility of the benchmarking and planning tool. So currently, analysis is ongoing for this component of the assessment. So I want to acknowledge once again the Ministry of Health. They've put in a lot of support to ensure that this goes through, the staff at the NLTP and the KNCV team from Dr. Mbenga and the rest of the team and our stakeholders that have participated in this. So thank you very much. And over to you, Mr. Chair.
Thank you so much for that presentation. So we've listened to the three colleagues from Ethiopia, the Gambia and Tanzania, who have shared with us their experience with the use of the benchmarking and planning tool. And all in all, they've all shared with us that some of the challenges that they identified with the tool prior to its use and implementation. And then they've shared with us the assessments that they conducted and how they then used engaged stakeholders to address the issues that they were identifying and planning for what to do next. And they've also shared the different lessons and made suggestions on how the tool could be improved or how it can be utilized further. So at this point, I would like to invite questions. I noticed that there were some discussions already in the chat. There was one question from Faith Su King, I hope I've pronounced that correctly, on whether there's a use of electronic data record in Ethiopia. I believe that appears to have been answered adequately. And then there's another one question about the use of TDA with regard to the speaker from Tanzania. I think Martina asked that question. If you're able to address that question now, so that we can go listen to the responses from our colleagues. If Martina, if you're not able to speak, then
yes, sorry.
Yeah,
sorry. So
please go ahead.
I understand you were asking me to speak. Sorry. Yeah, thank
Okay.
you very much. I wanted to ask Peter if he can give us a quick clarification. If I understood correctly, when he was mentioning the introduction of TDAs in Tanzania, he also mentioned that they saw a decline in pediatric TB notifications and that this could be due to an emphasis on bacteriological confirmation, laboratory-based diagnosis, over clinical diagnosis. But I was wondering if you think this is related to the introduction of the TDAs, and if this is the case, how they think they can address this, because actually the TDAs are providing stepwise guidance on both the bacteriological confirmation, but also the clinical diagnosis. So yeah, I wanted to ask if you can expand a little bit on that and tell us if he has any explanation or remediation plan for what they have been observing. Thank you.
Thanks, Martina. Dr. Peter Nima, could you please address that question?
Thank you again for a good question. And I've already stated that the TDA also employs other molecular testing and a lot of bacteriological confirmatory testing as compared to score chart. Therefore, that is the reason why before you put a patient to a clinical diagnosis, as you can see in a TDA, the last steps are the clinical diagnosis through X-ray or symptom screening or symptom scoring. But before that, you are supposed to undergo several bacteriological confirmatory tests. It's true that for children under 2 years, for children living with HIV, for severely acute malnutrition, and children with non-TB exposure, who have contacted someone with TB or have suggestive symptoms. These groups are emphasized to be treated first or immediately. But for the other groups, I say they're supposed to undergo those bacteriological tests. And I've already said that Tanzania has introduced apart from treatment decision algorithm, has introduced a new TB diagnostic algorithm which discourages the use of symptoms or clinical diagnosis for TB. And that has improved the bacteriological confirmation rates. Initially, they were below 40, but now they are near 70%. And that is being attributed to the use or introduction of new TB algorithm and for the TDA. But the TDA in Tanzania is not extensively adopted in different facilities due to financial constraints like capacity building and mentorship, and therefore we are expanding slowly. Thank you.
Thank you very much. I think Sabine in the chat pointed out that it's expected that the TDA should otherwise be helpful with people making a clinical diagnosis with or without the molecular testing. I'm not sure that Sabine wants to speak with that.
Thank you so much, Chishala. Yeah, I just wanted to point out that the TDAs, yes, they have the step of bacteriological testing. You know, of course, it's important to always try and get a bacteriological sample for bacteriological testing. Yes. But it is also clear in the practical guidance that is included in Module 5, the operational handbook, that if you cannot get a specimen or you expect important delays in getting the result back, you can continue with the next steps in the algorithm. And then, of course, there's the risk assessment in terms of those children who are at highest risk of rapid disease progression, the ones that you just mentioned, the kids under 2 years of age, children with HIV, and children with severe acute malnutrition. They should go through the algorithm immediately. The others, the algorithm doesn't say they first need to be tested, but they should be first treated for alternative diagnoses because they may have something else, not TB. And if they don't improve after treatment, say for pneumonia, getting antibiotics, treatment for malaria or anything else, and they don't get better, then they come back into the algorithm and then go through to the next steps. So while it's important to do bacteriological testing, it should not be a barrier for making a clinical diagnosis in children who you really strongly suspect they may have TB. Thank you.
Thank you so much, Sabine. There's a question regarding on how long it took to do this assessment and the experience about its use, whether health workers have found it cumbersome, and this is coming again from Martina. And I think to tie that up, there's also a question from Anna, who wanted to know whether or the speakers could tell us something more about the human resources and the time needed to perform the assessment. I think the two questions are closely linked, so I think I would invite all the three speakers to say something about this question.
Okay, thank you very much for this really very nice question. As the first presenter, just let me respond to that. Basically, the tool is not really, doesn't really need a lot of resources. It's not a resource intensive. But especially the first part, reviewing the type of desk review, checking all the indicators, and also getting the data from, as you know, in Ethiopia, we are using DHIS2 as a major data source. But there are a lot of indicators which, as I explained, which we cannot get the data from that source. So looking at other source of data, different strategic plans, different reports, systematic review, and all these are really, that was one which was really time consuming. But as a team, at KNCV staff, we are really staff, some staff together, we did that exercise. For us, that was really the major part of the work, which really time consuming, and also it takes time. It is a lot of effort really to bring all those informations. Even despite all those efforts, sometimes some of the information may not be easy. If there is no systematic review in that specific topic in Ethiopia, then definitely we'll lack the data. If some units department, if they don't have NSP, then the type of strategic plan, you may lose, you may not get the information. So collecting all these resources to populate the indicator information was really the one which is really taking a big time. In addition to that, which according to, as I explained, the age difference also, one of the big issue. Actually, it's not only the age difference, the STB type and the regimen, the aggregation between the country and the WHO, the DRTV, the TPT, this also some difference. So that part of the work was really the one which is really time taking. But if there are some dedicated team, that can be done. The other thing, before we conducted the workshop and presented the standard and benchmarking to the team, to the whole workshop team, we did it by ourselves, not only us as a KNCV Ethiopia, we involved national program people so that we field it, so that the workshop discussion will be very easy. So we presented, but we left to the team, to decide whether what we feel and what we said, whether it's made and made was okay or not. They can decide. During our discussion, some of them, they say, no, this is not made, some made. So we left the final decision to the team, but we presented it to really save time. Otherwise, going through each standard, each benchmark in one day consultative workshop, it was really very time consuming. It may not be easy. So that was the case. Otherwise, the facility assessment, because there is a questionnaire, then it was easy. The only thing is we have to customize it to our context. the FDG, actually the best was to do it during the workshop, but the workshop was immediately after the workshop, collecting the team and doing the FDG. But it was only a one-day workshop. We couldn't able to do it. But subsequently, because during the workshop, we came together, we understand each other. So we invited the same people to do it virtually. It went very well by itself also. So in general, I don't know which I responded to you. It doesn't go to the facility team to do the work. So that's the issue. If we are leaving it to the facility team to do it, that will be a little bit challenging. But it is done by a team of experts from different groups, so that it was completed this way. Thank you very much.
Thank you so much, Ahmed. So Peter or Mohammed, could you also just share your experience?
Yeah, thank you very much. Just to probably break it down based on what needs to be done. To begin with, the next review. Again, it would depend heavily on what type of data you have and how your data is disaggregated in your national systems. And not having the data in the national system is in itself, for us, we view it as a gap. We didn't try to go further to look at what other data sources we might use. But we feel we need to have it in our national system. And that's one of the gaps that we have picked up when we were doing the text review. So it took us roughly 2 days to do this. And depending on who is doing it, because if it is an agency or an institution outside of the Ministry of Health, it may take some time to be able to bring people together. But if it is the MOH doing it at their level, maximum, I think the text review should take nothing more than 2 days to be able to identify what is available, what is not available. So to the benchmark and standards, we did it in a day, where we brought together everybody that, all the stakeholders that could support in telling us what is done, what is not done, brought all of them together, and we went through the benchmarks and the standards, and we were able to complete it in 1 day. So the health facility assessment we did in 2 days. One was for 1 day in the urban areas and the other day in the rural areas. And this took us 2 days to complete. But however, our country is not also so big like other countries, so it would depend on how big your country is, which type of facilities you are targeting for the assessment. And we held the workshop in 1 day. However, the recommendations from the workshop was that the 1 day was small because we were quite late to complete the work that needed to be done. So I would say on average, probably 2 days. So in total, 7 days, this benchmarking tool should be able to complete depending on the complexities of our countries. But between 7 and 10 days, probably, it wouldn't take nothing more than that. Thank you.
Thank you so much, Mohammed. Peter, could you please also explain how you went about it in Tanzania?
Can you hear me?
Yes, please go ahead.
On the data collection stage, except for validation workshop, as another colleague has already said, 1 day is not enough for it. We had to move it to another day where we could find the stakeholders and they completed the exercise. Therefore, the validation exercise is not a single day exercise. And also, health facility visits required us to visit different regions. We visited Adolescent and Dodoma, so it was also time consuming. There is also a challenge when you reach at the facility, you find the healthcare worker, the dot providers who are supposed to ask you questions, attending some clients, so you have to wait. So for us, each facility took 1 day. And another time-consuming issue is on the data extraction and data analysis. That is my observation.
Okay, thank you so much for that feedback. There's another question for
Peter.
Peter.
Maybe I can comment a little
please,
bit also.
Please go ahead and comment.
Yeah.
Dr.
So to these questions, because I also we also receive comments from each of the countries also on each of the standards and benchmark, because also there were some standards and benchmark which can say that okay, they look like they are similar in one way or the other. For example, like in drug forecasting, so we'll have a question that is similar to some of the questions that are in the treatment and care. So, and those are areas also that we observe that the countries commented on them. So, and of course, we'll look at it and review all of those comments that we receive from the countries. So, and other areas also were missing in the benchmarking and planning tool, like the question that Martina raised on the treatment decision algorithms. So because these were not included, and we think that those are important things that we need to include in it. So, and in the next version, of course, so we'll revise that and make all these necessary changes. Thank you.
Thank you so much. Thank you very much. Then we'll probably, there's a question about the expert from that's from Zweli Nguwo, who's asking about the issues about expert availability in Tanzania and what is being done about it. I believe this is for Peter. Peter, are you able to answer that question?
Can you repeat the question?
The question is that you're being requested to expand a bit on the availability of gene expert in government facility, because you mentioned that Tanzania is looking at procuring point of care for TB diagnostics for the facilities. I don't know if Zweli, I'm not sure whether I've represented your question correctly. If you want to speak directly to Peter, you could
maybe repeat the question.
Yeah.
Oh, yeah. Good afternoon, colleagues. No, thank you so much for taking my question. Yes, you were right. This is to Dr. Peter. I heard the doc mentioning that all government facilities in Tanzania have the gene expert machines, but somewhere along the presentation as well, I heard him mentioning the need to procure the point of care diagnostics for TB. So I just wanted to check there. Maybe I misheard something.
No, about MWRD tests, we are having around 522 in our country, and the diagnostic facilities for TB are around 1,059, and total facilities in our country is around 9,600.
Oh, no, I get you, doctor. Thank you. Thank you. It's clear.
We have around 5,000 dot sites.
Oh, okay. No, that's perfect. I think it's clear now. Thank you.
Okay. Thank you so much. I think we will close the question and answer session. And
Mr. Chairman, I'm sorry, before you go on.
Yep. Please.
I raised a concern about the issue of scoring in the benchmarking tool, whereby in one area or one domain, if you have at least 3 questions, and along those questions, you get the response of met in 2 questions, and the last question is partially met, then the overall score for that domain is not met. And this poses a challenge because it undermines the government effort in different interventions. When you say that something is not met 100%, it has sparked this discontent from the participant of focus group discussion and validation workshop. They suggested that the scoring should also have an option of partially met the overall score.
Thank you for that question. So I'll hand it over to Dr. Mbenga to address it, and then I'll also I'll give him the opportunity to give the closing remarks to this workshop.
Yeah, Peter, thank you for that. So yeah, I think that's a remark that we received from all the countries that has used the benchmarking and planning tool. So, and is one of the areas also that we will review, because we understand that, yes, of course, if there are 3 benchmarks which has been met and one of them, is not met, so it will lead to partially met, so not showing the work that has been done. And this might be translated in another way in the concept of the authorities. So, and in that case, of course, we will review that section, so on the updated tool. So maybe then, yeah, before we close to this, I was having one question, maybe to Mohammed from the Gambia, just maybe to explain to us their experience or what have they been doing maybe for the past 10 years, as they don't have any DRTB case in children. So is this related to diagnostic challenges, or maybe there is timely identifications and initiation of TPT? So what's your experience behind it? Thank you.
All right. Thank you very much, Dr. Menga. I think other countries were equally looking into this. It's a bit complex. However, we have seen a very high molecular diagnostic coverage in the country. We have about 92% molecular diagnostic coverage for bacteriologically confirmed cases. And we did a DRS recently, which was completed in 2024. And both the study and the routine surveillance have not picked up a single drug-resistant case among children. The last one was in 2015, when we had the last childhood TB case. So it could be a number of factors. One could be that our TPT is working and that children are protected, or it could be that we are missing out on childhood TB cases, especially drug-resistant TB cases. But we can't say for certain. But the data currently shows that we are not having them in the country based on the high molecular diagnostic coverage and the drug-resistant survey that we just did recently. Over to you. Thank you.
Yeah, thank you very much, Mohammed. So yeah, and in that case, we will conclude the webinar for today.